What actually is cancer?
Cancer is when corrupted cells multiply uncontrollably. It can emerge from basically every type of cell in your body, so there's not just a single type of cancer, but hundreds. Some grow slowly, others are aggressive, some can be treated effectively, others are deadly.
I don't know about you, but that scares me. Fear, worry, anxiety.
Hello! I'm anxiety. Where can I put my stuff?
I don't think you want anxiety to fill your heart and mind. But what if you had the opportunity to talk with a doctor? Literally, a doctor who is a superhero, like Dr. Stone. Now, he may not be faster than a speeding bullet. He may not be able to stop a train with his bare hands, but he fights cancer every day and sees thousands and thousands of patients over his 25-plus career, and he helps families fight the battle of cancer. So stay tuned for this excellent podcast with Dr. Scott Stone.
That's fine.
Well, hey, thanks for hanging out and letting us talk about just oncology in general, and just mostly, I know you, we have a good relationship, but I think it's a lot of times families, it's scary when it comes to the word cancer, you know, and so I think you do a great job of keeping people calm, and so we thought, like, let's just chat and let's talk. So
happy to be here.
Yeah, if
Thank
you don't mind, just tell us about yourself and just in general how you got started with becoming a doctor and everything. So.
Well, okay. This summer will be 25 years from now.
Wow, really?
Yeah, 25 years.
Congratulations, that's cool.
Well, thank you. It's been a nice
You don't look
ride.
it.
I started when I was 12.
Hey, that's it. That's it.
No, it's been 25 years. It's been a good run. Wow. And I went to college and thought I started in business school.
Oh, wow.
Thought I was going to be an accountant.
Nice.
And realized after one semester of microeconomics that wasn't going to happen. So we didn't go down that road any further. And but I grew up in a house. My dad was OB-GYN.
Okay, cool.
So I kind of always had the medical thing on my mind.
Yeah.
And then in college decided to go pre-med, and it was a great decision. Ended up in medical school, and then did my residency in internal medicine.
Okay.
And ended up enjoying my time learning about oncology when I was in residency. And then got myself a fellowship in oncology here in Dallas at Baylor.
Wow.
And that was a couple years, and joined Texas Oncology after that. Been there since.
Wow. So how many years now with Texas Oncology?
25.
25.
Yeah.
One place. That's amazing.
One place.
Wow.
25.
That's rare too.
Yeah. I think for us, once you get settled and you're happy, and business, is good, then there's no reason to move around. So, and Texas Oncology has been great, and I've had a great experience there. It's been wonderful. So
that's cool.
So yeah, it's not too rare to be around in the same place for a while, at least with what we do.
Wow. So when you were in med school, you did the internal medicine residency. What were the things that kind of geared you towards, like, being in oncology, just in general?
Yeah. I don't know whether there's any one thing. However, I honestly think what got me into it was my very first day on the job in residency, I randomly got assigned to do an elective in oncology. And that's just what happened, day one. And my boss, my attending physician that month, was to this day probably the smartest, nicest doctor I've ever worked with.
Wow.
And I just followed him around, and he really got me interested in oncology. And even though that was just a 1 month elective, it just was always there, and I got to spend more time working with him as the 3 years went on.
Wow.
And that's really what piqued my interest, really, was working with him. So I did not go to residency saying I was going to be an oncologist.
Wow.
I didn't really know what I was going to do. I just wanted to get there and see what was best for me and with my personality, and it just worked out.
Wow, that's cool. That's literally the first thing, and then
day one. So it was just I don't know whether it was meant to be. I don't know about that, but it just worked out that way.
That's cool.
And it's just piqued my interest right away, and I kept going.
How many years was the residency?
3.
3, okay.
Yeah.
Wow, wow. And where was that at?
UT San Antonio.
Oh, cool.
Yeah,
Nice.
so
That's cool.
3 years of medicine, and then you do 2 years, or I did 2 years of medical oncology here in Dallas afterwards.
Wow, that's amazing. Wow. So medical oncology, let's kind of break that down for someone who doesn't, or even if students who are interested in going into that, what are some things that they need to know, and just like the definition of it, if you...
Oncology in general is taking care of patients with cancer. And there's medical oncology, which is what I do. We also do some hematology. About a third of what I do is benign hematology.
Okay.
But the medical oncology is obviously taking care of cancer patients and administering chemotherapy when it's appropriate. Chemotherapy is either in an IV or a pill form. And so that's what the medical oncologists do. Now there's also something called radiation oncology, which I don't do. We have partners that specialize just in that, but we all work together. There's many diseases where both radiation therapy and chemotherapy are used either sequentially or sometimes together to help fight whatever disease you're treating.
Wow.
And so we have in our office, we have medical oncologists and radiation oncology.
Kind of work together.
And we work together every day, sharing patients, back and forth. And it's, but radiation therapy uses forms of X-rays, to be very basic, to help fight cancers as well. So the two treatment modalities are used together, and some diseases need both, some need one or the other.
Wow.
And but we're fortunate in that we have both specialties under one roof. So it's very easy for patients to move back and forth whatever they need.
That's really neat, because then and then you're able to kind of work together as a team as well.
Yeah.
Wow.
Many offices have both radiation and medical oncology under one roof together. We're fortunate to have that. Some probably smaller practices don't have that luxury, and people are going place to place, which is still fine.
Wow.
But we're fortunate in that we can sort of have one-stop shopping if it's necessary under one roof.
Cool. That's cool. Wow. So we had a good friend of mine, another doctor that was on here. We had like a resident story. Do you have like a resident like story that you were like, wow, that was a crazy one? Do you have anyone that you think of that you're like that just stands out to you?
I do. I'm not sure they're proper for this forum.
Yeah, right.
So I imagine I do. Maybe I'll tell you some of those off the camera.
That's
so
cool.
they're maybe maybe not PG.
Right. So maybe just summaries like long hours, right? Like
well, I mean, everybody has that, long hours, and it's looking back on it, it was good. Some of those long hours were tough, but that's the way it is.
Yeah, that's crazy. That's crazy. So say for instance, let's talk about someone. The word cancer, it's just like, it's scary, right?
Sure.
What are some things that you do when you walk into someone and they get diagnosed with cancer? What are some things that you help that whole process? Let's just say someone just gets diagnosed.
Yeah.
And you walk in, like what is that like? Or just walk us through that.
Well, one thing is for me is that, very honestly, in most cases, I'm not the one setting up whatever procedure is necessary to make the diagnosis.
Okay.
So well over 90% of the time when somebody comes to see me for the first time, they already have the diagnosis.
Okay.
So I'm not the one breaking it to them. That usually they've had a biopsy done, or a surgeon has seen them, or a gastroenterologist or whatever, and has done whatever procedure and has actually found the diagnosis, and so they're told by the other physician that they have something, and you need to go see a medical oncologist. So by the time they get to me, it's sort of
kind of settled.
It's sort of soaked in a little bit.
Wow.
And of course, obviously, people are appropriately nervous.
Yeah.
And they've got a million questions, which is obvious. And but obviously, emotion is a big part of it still when they get there. But it's pretty rare that I'm the one breaking the news. And so it's they're calm when they get to me in most cases.
Okay, good. So now, so that's a good thing, because then it kind of helps you kind of really focus on the treatment plan.
Sure.
I'm guessing, right? So
well, it makes it easier because when you're given a life-changing diagnosis like that, especially right off the bat, you're probably not hearing anything else.
Yeah.
So it would be tough to say,
here's the plan.
Here's what you have, and here's the plan, and expect somebody to absorb all that. You
Wow,
know, because
wow.
I mean, I think any person
Yeah.
who is new to this, you know, especially a new diagnosis, doesn't know anything about it.
Yeah.
That would be a lot to absorb all at once. So
Yeah.
it makes it a little bit easier for me to be able to go over, you know, the process and the
Yeah.
plan,
Yeah.
because they're, you know, they've got an idea. These days, you know, most people have researched it, looked it up on
Oh,
the
goodness,
internet,
yeah.
you know, Googled it, whatever.
Yeah,
And so oftentimes people come in with a whole list of questions and good questions.
Wow, wow.
And so people are pretty prepared these days.
Wow, wow.
Compared to 25 years ago or even before that, where the internet wasn't available and they didn't have access to the information. So people are often, especially in this Collin County area, you know, a lot of educated people here, and they do their due diligence before they come in.
Wow, wow.
Yeah, many do.
Wow. So when you are creating a plan, you mentioned that either IV or pill form specific chemotherapy. How do you curate a plan for a specific type of cancer?
Well, all tumors are treated. All different tumors are treated differently,
Okay.
and there are mountains of data as to how to treat whatever the problem is. And so we have guidelines and pathways that not just our group but across the country that we have to follow. You know, insurance companies won't pay for treatments if they're not standard of care treatments, obviously.
Wow.
So you know, obviously whenever you it's not the same for each person. Some people come in at different parts of their journey, you know, in terms of have they had the biopsies, have they had the proper tests, have they had the scans. So you know, you got to start with wherever the patient is. But you know, once all the information's there, we can talk about the treatment, whether it's, you know, pills or IV treatments, whether you need radiation, do you need more surgery. So there could be a whole bunch of things that are you know, needed at the beginning of the journey for the patients, and so we see where they're at, and you know, make sure that they're healthy enough to get whatever the treatment's going to be. You know, you got to take everything into account.
Wow.
And then come up with a plan.
Wow, wow. Have you had some, over the last 25 years, have you seen some plans that have worked really well and some that haven't, or like just
Of
curious?
course,
Yeah,
of
yeah.
course. I mean, you know, you're going to have a different situation with every person. You have 10 people with the same disease, you're going to have 10 different problems and 10 different outcomes, and people are going to tolerate the medicines 10 different ways. So you never know, you know, and so you say, this is what we're going to give you, this is what to expect, and call us if there's problems, and we'll get you through it, walk you through it as best we can. But you never know what's going to happen from patient to patient. You've got an idea, and you go over. You know, you give them all the information you have, but honestly, it's a different ballgame from person to person. Yeah,
and how their body reacts to it.
Exactly. Yeah, I mean, everybody's different.
Wow. Now looking at your team, like what are some key people in your team that kind of help with that whole process?
Well, yeah, I mean, it's a lot. It's a big team. First of all, you know, the people that get them to us, all of our consultants are still part of the team. You know, a surgeon does whatever that person does and sends them to us. Well, we often need them later on for other things, so they're still part of the team as well. So our consultants are certainly part of it.
Oh, well, yeah.
But I mean, the team is huge from the minute they make the first phone call. All the intake staff and all the front desk people in the business office, and of course, then you know, our medical assistants, our nurses, our lab technicians, all of the staff in the office. I mean, there's a whole team in place to help out.
Wow. During that, you know, when you're in that treatment plan for a patient, there's specific procedures that you can do, outpatient procedures. Is that correct?
Well, yeah. I mean, most of our treatment is outpatient.
Okay.
You know, surgery in the hospital. Sometimes that's outpatient too. But the majority of the chemotherapy that we give is outpatient.
All of it,
pills, take it home. IV is given in the office now. Are there some protocols where you have to be in the hospital? Some IV protocols where the medicines are given over 24 hours or maybe even over 48 or, you know, however many days. So some regimens you have to be in the hospital for. Most of them, however, are given as an outpatient.
Gotcha.
Sometimes you're in the office for 30 minutes. Sometimes you're there for 5 or 6 hours. Sometimes you come once a month. Sometimes it's 5 days a week. I mean, it just depends on the disease and the specific treatment for it. Radiation's also done as an outpatient. It's very, very rare that there are very few places around the country where there's inpatient radiation therapy. So radiation is almost exclusively an outpatient treatment. But chemotherapy is nowadays too. Now complications sometimes land people in the hospital, whatever those may be, infections, you know, things like that. But the majority of our treatments these days are outpatient in the office.
Wow. Do you get families that see? I'm sure you get this a lot, but you see like they see a specific type of chemotherapy or drug like somewhere, and they come to you and you're like,
of course.
Doc,
right?
Like, how do you?
I mean, of course. I mean, you know, commercials on TV and just getting on the internet. There's, you know, information all over the place now.
Yeah.
And like I was saying earlier, people come in prepared, and they say, you know, I'm told I've got this, I want this. Well, sometimes that's right, and sometimes it's not necessarily right. And I said a few minutes ago that we have guidelines and pathways for every disease that we treat, just about. And so sometimes, you bring in this information, and let's talk about why it's right or why it's not. And go down that road.
And so it's literally kind of walking them through this. Okay, I hear you. Looks good, but we have to make sure we're doing it the right way. Kind of.
Sure. I mean, you know, you know, we have to be honest and say, look, you know, your point's well taken, but this is why we shouldn't do this, or this is why we should do that. And usually it's not a difficult conversation. I mean, people don't come in and say, I want this or else. You know, you just got to explain why it's right or wrong.
Wow. How do you as a doctor, you know, the work-life balance, we talk about this all the time, you know, dealing with patients who, you know, you've taken care of them for a while and then they pass away. You know, like how do you also handle that? You know, just curious.
Well, I don't know whether I've got some you know, way of doing that for everybody, of course. But of course it's tough. But you know, oncology, people die of all kinds of things, not just cancer-related stuff. And you know, everybody, I get asked that question a lot. But you know, heart disease is the most common.
It is,
you know, problem in the U.S. 100%. And so cardiologists deal with the, you know,
almost sometimes more.
Yeah, exactly. So, but still, you know, you luckily these days, the treatments allow oncology patients to live much longer than they used to.
That's true.
And so you do build relationships with many of your patients, of course. And sometimes it is tough, you know, when somebody passes, of course. And the way I look at it is, you know, for many of our patients, the treatments that are available today help them live a lot longer than they would have otherwise. So if you look at it like we help these people longer than they would have otherwise, then you feel like you
give them more quality of life.
There was, you know, some good that came out of all this. And that's the way I kind of think about it. You know, we were able, with the medicines and the treatments, you know, we were able to help these people live longer than they could have otherwise.
That's really
and
cool.
So it gives you some peace with that as well. But it's hard to not get, you know, emotionally wrapped up with all these people. But you've got to keep it at the office. I mean, you got to have your home life. I mean, and true of any business, you know, I think you got to leave work at the office and then focus on your family when you're home. And but some days are tougher than others. There's no doubt. I mean, you know this probably better than I do, being in the hospce world. I mean, you deal with life and death more than I do, honestly. But you gotta, you know, you obviously have empathy and you know for your patients, but you got to leave it at the office.
Yeah, it's funny you said that, because me and one of our social workers and our bereavement coordinator, we were just talking about that, because we had like 8 deaths in like 2 weeks, right? And so we were talking and we were like, man, this is like really heavy, you know, like, and so we do this kind of like thing that we were talking about. We have like each person has like their own like patient journal, where they kind of like write down the good, the bad, the things that they learned, and then kind of like just outlet, you know. But of course it's to keep it HIPAA, so it's just for themselves, right? And so, but I was like, yeah, it's crazy that you said that. It's like sometimes you get hit with so much stuff, and that's just anybody, like whether you are an oncology doctor or a cardiologist or a teacher. Like death is certain, and I think like a lot of people don't realize that you just have to have those like outlets. It's
yeah. I mean, everybody handles it differently.
Yeah.
I really don't think that at least the people that I know and work with are cold. It's just like you're not a robot when you go to work, and of course emotions are going to get into it.
Yeah.
But you just got to compartmentalize. Is that the right word? Compartmentalize. And
Yeah, it's interesting, but at the same time, you look back, you're like, well, you just keep going.
Yeah.
But it's not like a bad thing, right? It's
Correct.
like you have to keep going mentally so you can take care of the next person.
Right. That's right.
And then you keep going. So that's really good. That's really good. Yeah. What are some things that that you look back on the last 25 years, some things that, say for instance, there's a new doctor who's thinking about going into becoming an oncology doctor. What are some advice that you would just give? Just like that you said you had a supervisor or someone who oversaw you. What would you kind of say to someone who's thinking fresh into?
Yeah. I think that that oncology is a really great field because it's just changing so much. It's hard to keep up with the new treatments because they're coming out, every month there's new treatments for this or that, and that's wonderful, but and it's exciting because it's there's just the treatments today are so much better and different than they were 10 years ago, and then 20 years ago and 30 years ago. The way we treat things compared to when I started day one is for almost every disease totally different. So that's interesting. Now
Constant learning.
I mean, that's true of most of our fields. True. I mean, even general practice. I mean, things are different than they were years ago. Things evolve and change. But my advice would be, not specifically for oncology, but you got to go into something that you enjoy, and that's, in my opinion, good for your personality.
Yeah.
There are certain specialties I know I would be awful at, and there's others that I think I would be okay at. And I said earlier, this oncology when I was in training just seemed to fit my personality better than some of the others. And you got to go with that when you're getting started, because if you get into a specialty that it's not a good personality fit, it's going to be difficult, and you're not going to enjoy it.
Wow.
So my advice would be to what are your interests, and what fits you better than anything else. And I think that's true for most things.
It's true. Yeah.
But it's rewarding. It's tough. It's rewarding, but true of all specialties.
Yeah, that's true. Wow, wow. Is there anything that, as you look back, also you talked about the different, I guess there are different areas that you can go into, whether it's the hospital or outpatient, or what are some areas that what got you into that realm for outpatient?
Well, when I started, let me say it differently. Now, in probably, I guess it's been 16, 17, 18 years, there are specialists called hospitalists. And those doctors only work in hospitals, or primarily work in hospitals. And they play a very vital role, and we work with them all the time when our patients get admitted. Those type of doctors, hospitalists, do not have offices where they see patients as an outpatient. So they're solely to facilitate patients having a smoother ride through the hospital, whatever it is. When I was in training and getting started, that wasn't even a specialty. Wow. So I mean, it wasn't even an option. Not that I probably would have done it, because that's not my personality. But that is there now, and so you can choose when you're getting started. Do you want to have an office where you really follow patients long term and build relationships, or are you more focused on taking care of acute problems, getting them fixed up, tidied up, and then get back to their physicians as an outpatient?
Wow.
Some people love that, and some people don't. It's kind of like an emergency room doctor.
Yeah, that's true. Yeah.
They don't see patients long term. They take care of the acute problem and move the patients along.
Wow.
So nowadays you can choose. Do you want to be an inpatient doctor? Do you want to be an outpatient doctor? There's much more. There are fewer inpatient doctor spots. There are just fewer positions across the country for that. But if that's what you enjoy and you like just, getting your scrubs on and rolling up your sleeves and doing that every day, then that's for you.
That's cool. Wow. And I didn't realize that. That's very true. There are, like, just like we talked about before, there's different, what fits your personality is the best kind of road to go.
Absolutely.
When it comes to, that's really good.
And, some people like building relationships with their patients. Some people not so much.
Yeah.
And,
cool.
just to each his own.
That's cool. Wow. Yeah. Wow. What if, now in regards to that, walk us through like just a day in the life of Dr. Stone. So like, let's just say you wake up, have your coffee. If you don't mind, walk us through like, what does it look like to be at the clinic or at the office?
Yeah, it's, everybody does it differently, so all I can tell you is my situation. But I'm fortunate to have a very busy practice, which is good. And I get to work early. I get out. I'm a morning person, so I like getting the day started. I prefer to get going early and get home at a reasonable hour as opposed to the other way around. I have partners where it's completely opposite. They show up late morning and go home late night. Good for them. Everybody's different. But I like to get there early, and personally, I see my list of who's coming in, and I go through the computer looking at what was done recently. Have they are they here for treatment? Are we going over CAT scans? Are we going over pathology? And I kind of get all my ducks lined up for the day, so to speak. And I can't. I need to be. I need to be prepared when somebody comes in, as opposed to just kind of trying to figure it out on the fly.
Right.
And so I get there, I get everything lined up. I have a plan. If I have, if I'm expecting a report that's not here yet, I can ask people to help get them for me before they show up. And so I try to be as prepared as I can when they get there. Sometimes a new diagnosis, I've got to figure out the treatment plan that morning and know what I'm going to be talking to them about, and then get my nurse to get whatever information gathered that we're going to present to the patient as well. So so I get going early. I try to get everything ready to go before the morning starts, and then the phones start ringing and the patients come in and you just go.
Wow. How many, like, on a very, very busy day, how many patients do you think you see?
My average is, I try to see 15 to 20 people a day.
Wow, okay.
Sometimes it's less, sometimes it's more. It can get pretty pretty frenetic as the day goes on if you get more than that. For me, some people
kind of stay in that good. That's
Sometimes some docs see more than that, some less. It's for me. I try to see about 15 to 20 people.
That's
a day.
Cool. Wow. That's a busy day.
It's a busy day. So, but it's good.
That's cool.
Yeah, keeps the mind working.
Yeah, that's good. Hey, if you haven't already, make sure you like and subscribe. The YouTube algorithm told us, what they tell us? It told us it was like 99% of our people watching these videos are not subscribed. So that means you need to subscribe, and hope you continue to enjoy our content. All right, bye.
Are there any like new or advancements in technology or just research that you're really looking forward to?
The answer is yes, but am I going to be able to give you something specific? No. I mean, I do not work in early phase 1 and phase 2 studies. At our office, we do have research at our office, a small research department. We're in Plano. My office is in Plano, but we're part of a very large network across the state, and also even a larger network across the country. So we have access to literally dozens, if not hundreds, of different studies that people can potentially enroll in. Again, a small amount of studies are available where I'm at, but we can refer people down to Dallas or even somewhere else in the state if necessary for research. But I'm not intimately involved with early stage phase 1 and stage 2 research studies. I've had patients that are on those that come back and forth, and we help out with whatever's going on when necessary. So there are so many trials going on for all different diseases right now that some are more exciting than others. And since I've been in practice, we've had patients on studies where those treatments became approved, and so that's really exciting that we're involved in the early stages of whatever drugs end up becoming available and are used every day.
Wow.
So Is there anything specific that I can say that answers your question? No, but I mean, studies are just going on all
Constantly.
the time. Yeah.
Wow.
Yeah.
That's crazy. I didn't realize that's it's a constant, like, research is never
Oh,
stopping.
it's going all the time.
Wow.
And even in the DFW area, there are several clinics. I'm part of Texas Oncology.
Yeah.
We have our own huge research department that we can easily refer our patients to when it's appropriate. If Texas Oncology doesn't have the proper study, there are other places either in Dallas or, you know, there's MD Anderson in Houston. I mean, there's all kinds of places that aren't too far away for people to at least get information or enroll in studies. And so it's nice to have that available, and it's ongoing all the time. And for somebody who doesn't do that 24 hours a day, it's hard to keep up with those studies because they're opening and closing all the time. And you know, so if somebody is a brand new patient and asks me about a research study, I say, you know, if you want to, some people want to be involved in research studies right off the bat, and that's great if that's what they want. Most people will go through the several treatments that are approved, you know, that we can give them in our clinic. And when we run out of treatments, if you go through 2, 3, 4 treatments, whatever, and they're not working, then I'm the first to start talking to the patients about we need to look at research. And but don't ask me today what research is available, because if you're not ready for it for 2 years, who knows what it's going to be.
Yeah.
So I mean, it could be a completely different situation when the time comes.
Wow. So you mentioned stage 1 and stage 2. Phase
Phase
1?
one,
Sorry, phase 1.
right.
What does that entail? I guess.
Sure. I mean, phase 1 studies are really, really early studies where they're really trying to find out mostly how well people are going to tolerate the drugs. And so those are kind of rough sometimes, but they're necessary and they're appropriate for the right patient.
Wow.
But their phase 1 studies are looking mainly to see how well drugs are tolerated, find the right dose that's tolerated, that kind of stuff. And sometimes even with early phase 1 studies, you find a drug that really looks like it's going to be something one day, and then those move on to phase 2. And phase 2, they really start, you know what dose is going to be tolerable, and then they start really looking at how well it's going to, they start getting more information about how well it's working and how patients are doing and surviving. And then stage 3, you start sometimes comparing them to other drugs, some standard of care drugs. Now, that's a very, very basic outline of phase 1, 2, and 3. But basically, that's how it goes.
Wow.
And sometimes it's appropriate for a patient to look at a phase 1. Sometimes it's more appropriate to look at a phase 3. Again, I don't personally start those studies for us. So we have an army of people in Texas Oncology that do those type of things. So when it's appropriate, we get them involved with those doctors, and they take over.
Wow. Is there a stage 4 or no? Or phase 4?
You know, there are phase 4s, I think, but it's usually 1, 2, and 3 are the most common.
Most common ones. Wow.
Yeah, the most common.
Is there like I'm curious, is there like a I don't want to say test group, but like in that phase, is there like a certain amount of people that they have to make sure that they go through and see how many people have gone through the phase 1? And
I mean, there's the amount of detail
it's a lot,
that goes into these studies, and it's unbelievable.
Wow.
What's the word I'm looking for? Just how
robust, or
I mean, I'm not thinking of the right word, but the amount that goes into getting a drug off the ground is amazing.
Wow.
And it's very, very detailed. You have to go through you have to have a lot of patients, you know, that are in most cases that have been through these trials, and these trials go on for years. I mean, you need to have somebody on a medication, and you know, it's not how does it work today. It's, you know, how are they alive and well in 2 years and 5 years and 10 years. So these studies can take a long time.
That's amazing. And then you mentioned before, like insurance. How does insurance approving or not approving those, right?
Well, with
or
research, insurance is not really that big of a deal, because for me and for what we do, insurance is obviously a huge you know, part of the whole situation, and that's why we can't use drugs that are not approved, and that insurance won't. Insurance pays for drugs that are approved.
Yes. Okay.
And so that's what we do.
Wow.
when drugs are in research, when they're going through those phases of trials, the drug companies sponsor those and pay for it because they're trying to
push ahead.
they're trying to find their product that's going to be
Wow.
good one day and will be helpful to people one day.
Wow.
So the drug companies that are making those specific drugs pay for those trials.
Wow, that's amazing. I know there's a lot probably on social media about things that could help cancer outside of chemo and things like that. Is there things that you've seen or over the last 25 years that just good basic things that can help with cancer or just general?
So are you talking about homeopathic things?
Yeah,
and stuff like
or just
that?
anything. Yeah.
Absolutely. I mean, of course there are. And we do not treat with homeopathic type thing. That's not what we do. And I am not ever going to tell somebody they shouldn't do those things. Now, patients come in all the time and they say, I've heard about this, or Aunt Sally did this, or whatever.
Yeah, exactly. Yeah.
And my only concern is that whatever I want to know what they're doing, because I want to know as much as I can whether it's going to interfere with whatever treatments we're giving them. And so if somebody brings something to my attention that says, or it's
beet juice.
Beet juice is pretty benign. There's a lot of interesting stuff out there. You can imagine. But in most cases, what people want to do, it doesn't sound like it's going to interfere. It's not going to be harmful. But have there been things where it's clear that there's something in whatever the remedy is that they're looking at that will clearly interfere with what we're doing, and then we have to say, look, that's maybe not the smartest thing to do. But I'm not here to tell people that these homeopathic treatments are not helpful. Just as long as they're not interfering with whatever our goal is. Not my goal. Our treatment goal with the patient. As long as that doesn't look like it's going to interfere, then go from there. But
name one crazy. Is there a crazy? So we heard something it's really crazy.
Well, when people get desperate and they start, going out of the country sometimes, and there's all kinds of crazy stuff out there, and who am I to say that stuff's wrong? But a lot of these things haven't been put through trials, so you gotta take it with a grain of salt. A grain of salt with whatever you're doing. And then it gets expensive.
Oh yeah.
Because insurance isn't covering that. So
and it's out of the country too.
And there's nobody's overseeing whatever's going on there.
True.
So be careful.
Wow, that's really good.
Yeah.
What you got?
I was gonna say it's during COVID, the orange peel thing.
Yeah.
I was gonna ask. It's kind of similar in a way, but holistic medicine. How does that come into play?
Same thing. I mean, that's when I was talking about homeopathic, that to me is the same type of thing. And oftentimes people do one thing or another, and we see that they're getting benefit, whatever it is. So I never tell patients or families that they're crazy for doing something, because very honestly, I don't have enough information for a lot of these things to give an educated answer as to whether this is good or bad for them. What we do is we follow national guidelines based on years and years and mountains of data for why this protocol is the best thing that we know of today for whatever your problem is. And so and not just my office, I mean most oncologists across the country follow these guidelines. And so the treatment that you get in DFW should be pretty much the same as you get anywhere in the country. Holistic, homeopathic things, it's just not what we do. Not that they're wrong, not that they're right, it's just not what we do. And as long as it's not interfering with the treatment, as long as I don't think it's going to add toxicity to treatment and that kind of stuff, then then we sometimes work together on that.
So now let's talk about you mentioned when we've had this discussion, because we worked in the hospitals together, and we would see patients here and there. But how does a patient if they end up going to the hospital, when they're under your care, and they do see a hospitalist that's maybe rounding at that time, and maybe it's a hospital that's not where you have rights, how do you coordinate that? How does that coordination take place?
Most of our patients know that if they need to be hospitalized, to come to the hospitals where we work at every day.
Okay.
Sometimes that can't happen for one reason or another, and that's That's understandable.
Yeah.
Being part of Texas Oncology is really helpful for us.
Oh, yeah.
Because let's say one of my patients is in Fort Worth, for example, and gets hospitalized. Well, I can get on the phone and call one of my partners that works at whatever hospital and say,
yeah.
hey, you know, this patient of mine has been hospitalized, do you mind helping out? And you know, we do that when somebody ends up in Plano. Our partners do that when somebody ends up somewhere else. So it's a huge group, and we can work together on that. And so it's really not difficult to.
That's good.
And so even though, you know, if somebody ends up in Fort Worth, one of my patients or wherever, I can't personally go see them. I don't have privileges at that hospital. The doctor that can go see them, you know, usually can handle whatever it is on their own, but they'll call and say, hey, you know, this is what's going on, and you know, either just give me you know, the heads up as to what's going on, or you know, say, you know, this doesn't sound right, what have you guys been, you know, just to get the story from me as well. So we all work together on that, and it makes it pretty easy.
Man, that seems like it gives a lot of peace of mind to the family too. Like especially if, like you said, if they're in Fort Worth and you're here,
Sure.
that doc can pick up the phone, you can coordinate, and that's really
I mean,
neat.
it you know, it whatever the specialty is, but I think especially with oncology, I mean, patients want, if they can, to have their doctor come by.
100%.
Sometimes it's not possible. You know, sometimes it's a holiday, and you know, one of our partners will be covering, and most people understand that.
Yeah.
But especially if something happens in a different area, and they end up somewhere else, then in most places there's an oncologist, usually part of Texas Oncology in this area, that can go by and help out.
Wow. Have you ever had where something happened where they're overseas or somewhere?
Oh, yeah.
How does that work? Just curious. I mean, like,
you know, it's different, but I've had, you know, doctors call me from Germany or you know, different places, and you know, your patient such and such has been hospitalized for whatever reason, and it's not, you know, they are calling just to gather information, and we say, you know, this is what we've been doing, this is what's going on, and then they can use that information to do with whatever they need. So it's, you know, in most places in the world these days, you're hopefully going to be able to find some good care. Third world countries, maybe not so much. We don't usually get phone calls from those places. But yeah, I mean, it happens. It's not very common, but it happens.
Wow, that's good. That's good.
Sure.
That's good. Is there any, as we kind of close, is there anything that you think that would really help patients as they're, you know, trying to find an oncologist, or you know, what are some things that you would advise them for, just in general?
I think, you know, it's going to be hard to research and get all the information that you want about your doctor just from reading something online. Most of the time, when a patient comes to see me, they have been referred by somebody that I've worked with for a long time. And I mean, if you have a doctor that you trust, and then that doctor refers you to who they work with, I mean, that's really the way things work the best, in my opinion. I could, you know, or anybody could have glowing reviews online, and then you go to meet them and it just doesn't work. And the opposite is true. You know, you may read something you don't like, and you meet the person, and then everything kind of works out. So I think you need to take the advice of, you know, a doctor you trust, or whoever your referring doctor is, as opposed to just picking a name out of a hat. And you know, if you trust somebody and they give you a name, usually that's going to work out pretty well.
That's good. That's good.
So, but you just got to, you know, you do your due diligence, read up, but you got to go interview. And look, there's nothing wrong with getting second opinions.
That's true.
You know, there's nothing wrong with that. It, you know, it never hurts my feelings when somebody sees me and goes and gets a second opinion. At the end of the day, you got to be comfortable with, a patient has to be comfortable with their doctor, and has to be comfortable with the plan. And if something just doesn't sit right, then you need to, you know, to look, you know, and try to find the best fit for you.
That's awesome.
And you know, it's not every doctor's not everybody else's cup of tea. It just doesn't work out that way. That's true. And that's true of any line of work. So you know, get the referrals from somebody you trust, and go interview, and make sure you're comfortable.
That's cool. If anyone needed your services, how could they reach you, just in general?
Well, we're online, obviously. I'm part of Texas Oncology here in Plano. It's easy to look up, and our information's all over the internet there, so it's easy to do.
Cool, awesome, man. Thanks for hopping on. This was great. This was
Thank
fun.
you,
Yeah,
and
yeah.
I want to say we've worked together now for several years, and you and your company are fantastic. Our patients have nothing but excellent things to say about all of your care. And I'm not just blowing smoke at you here. I mean, you guys have a great reputation, and our patients have nothing but good things to say. So, you guys are, not only do you provide a service to the patients and their families, but you guys really are a liaison between the patients and us. And you guys are doing great work. So we appreciate it. Absolutely. Absolutely. Thank you for inviting me.
We'll have to do this again. This is fun.
Anytime.
Awesome.
Anytime.
Cool.
Thank you.
Thanks for watching this week's episode of Charlin Care Pods with Dr. Scott Stone. Feel free to like and subscribe and check out more content on our channel. God bless. Have a good one.